I don't have any conflict of interest that I am aware of, no financial ones anyway. Next slide, please. So the outline of today's talk, I'm going to just talk about some of the basic science that underlies vaccine technology. I'm going to spend some time on vaccine safety, cautions and contraindications, a little bit of time about vaccine myths, and then we'll go over the individual childhood vaccines. This is only about childhood immunization. So adolescent immunization was a little too long to add to this. So we'll do that at another time. If you'll go to the next slide. Um, oh, great. Now my Surface Pro finally connected. Let me get out of this. There, it only took it 15 minutes to connect. Bruni, I need a new computer. But before we start,
Working on it. I'm working on it.
I wanted to, we're going to start with a pretest. So in the 20th century, okay, that was the last century, what medical intervention or public health action do you think added the most years of life expectancy? Now, this is during the 20th century. Was it A, basic sanitation like water and sewage systems? Was it antibiotics? Was it childhood vaccines? Was it the development of various heart surgical procedures? Or was it statin medications? You don't have to put yourself out there, but just in your head, think about what's the right answer here. And then we'll go to question number 2. And it's basically the same question, except what added the second most years of basic life expectancy? Same answer choices. Was it sanitation, antibiotics, childhood vaccines, heart surgery, or statin medications? So I'll go ahead and give you the answers now. The answer to number 1, which added the most years, it was actually basic sanitation. So clean water, sewage systems, and a food supply that was not horribly contaminated. The thing that added the second most years of life was actually childhood vaccines. So I have often said that public health nurses and garbage men and sewage workers should be paid a lot more than doctors because they actually add a lot more years of life to the public. Next slide. So I just want to go over some basic definitions. Immunity is basically the ability of the body to recognize its own cells and to tolerate itself. At the same time, recognizing foreign material, that is non-self, and getting rid of it. Now, we have basically 2 parts of our immune system. There's the innate immune system, which is really a non-specific defense system. That's things like our intact skin, intact mucous membranes, white blood cells. And then there's the adaptive immune system, and that's the part of the system that actually develops specific defenses. So defense against specific organisms like bacteria or viruses, or to specific toxins like the diphtheria toxin or tetanus toxin, or to other antigens like fungi and stuff. Next slide. So what is an antigen? Well, an antigen is basically any foreign substance that's not part of yourself. So it could be a live organism like a bacteria, parasite, fungus, virus, could be a toxin like tetanus toxin. And usually an antigen will trigger the immune system to respond in some way. Now, that so-called immune response could be the production of antibodies, and that's called humoral immunity, or it could be the development of certain types of cells, such as T cells, B cells, and that's called cell-mediated immunity, and that's in response to an antigenic stimulus or an antigen coming into contact with the immune system. Now, an antibody is actually It's also known as an immunoglobulin, and these are specific proteins that are produced by B lymphocytes, and those help eliminate antigens in various different ways that I won't go into all the detail on that. But next slide, please. So some people spend most of their lives studying immunology and get PhDs and stuff. I'm going to give you about a 3-minute overview of human immunology. So what happens when an antigen enters the virus? And this little cartoon picture here shows looks like it's more or less SARS-CoV-2. It's an RNA virus. So it attaches and enters our cells, and it starts to replicate. Well, the virus is taken up by specialized cells called antigen-presenting cells. There are various types of these. And they present the virus for recognition by the immune system as foreign material. And then special T cells or T lymphocytes called T helper cells come into the picture, and they actually recruit other types of immune cells to help out. That's why they're called T helper cells. Next slide. So the T helper cells then stimulate B lymphocytes to make antibodies. And it stimulates other types of T cells or T lymphocytes, specifically cytotoxic T cells, that can actually recognize these viral antigens, or if it was a bacteria or fungus or whatever, and they can destroy the cells that are infected by the antigen. Then the body produces memory cells, and those come in two varieties. There are B memory cells and T memory cells, and those will stick around for years or maybe even for the person's life. And if you're ever in contact with that antigen again, those memory cells sort of wake up, proliferate, they multiply, rapidly divide, and they produce antibodies, the B cells, and they produce cytotoxic and other types of T cells that will then mount an immune response and hopefully take care of the problem. Next slide. So that's a very, very high level overview of immunology. Well, what about vaccines? How do they actually work? Well, in a nutshell, vaccines mimic a natural infection without you getting the actual disease. That's kind of cool, actually, I think. So they take a substance, they being, vaccine developers, they take a substance that mimics a natural antigen, and they make it into a vaccine. Vaccine is then put inside the person, either by injection or some are actually oral. The immune system responds and makes antibodies. And sometimes also there's a T cell response, but pretty much all vaccines will elicit a B cell type humoral immunity. Really good vaccines will do both. They'll give you the humoral immunity and the cellular immunity, so the B cell and the T cell response. And then they create those memory cells. Next slide. So as I said, a vaccine allows a person to develop immunity to a specific disease without actually having to get the disease and be sick with it. Now, in some cases, vaccine immunity is not as good as it would be with the natural disease, but in many cases, it is as good as with the natural disease. We have eradicated a major killer, smallpox, through vaccination. And then many, many other diseases like pertussis, measles, polio, mumps, COVID, influenza. We've greatly decreased death, suffering, and disability from those diseases. So there's the potential to eradicate a second disease, polio, and I'll speak a little bit about that when we get to polio. Next slide, please. Many people worry about vaccine safety. The ideal vaccine would be safe. It wouldn't have any serious adverse effects. It would be effective. It would produce both a B cell and a T cell response. It'd be inexpensive to develop and manufacture. It'd be easy to make lots of it and easy to give to large populations. And it would also need to be proven efficacious in diverse populations. In general, for a vaccine to be approved by the FDA, it has to demonstrate at least 50% efficacy in large-scale trials. 50% doesn't sound like that's great, but if you could eliminate 50% of symptomatic disease, that's actually that's a big deal when it comes to serious diseases. Next slide, please. And by the way, most vaccines that we have better than 50% efficacy. There are about 8 different major vaccine technologies. If you'll go to the next slide, I'm not really going to go into these. That would be a whole separate talk. 3 of them are rather old. The very first vaccines were that we know of were smallpox, and that was actually very much a live virus. They used cowpox, which is related to smallpox, and by giving people cowpox, they could prevent them from getting smallpox. And that goes all the way back to the 1700s, and even further than that, it was actually first developed in China hundreds of years ago. But really the first modern vaccines were inactivated vaccines. Inactivated vaccines generally only produce a B cell response, but that's in many cases good enough. And then more recently, recombinant genetic technology has allowed us to produce something called protein subunit vaccines. These were first developed in the 1970s, 1980s. First successful one released in the US was the hepatitis B vaccine in the mid-80s. There are 5 newer technologies. The one that you're probably most familiar with are the messenger RNA vaccines. Next slide. So let's change a little bit here and talk about the development of vaccines, how they're developed, and what safety measures are taken. Before they're ever given to a human, they're extensively tested in animals. These are usually rats, sometimes mice, hamsters. And then after they've decided that it's safe to give to those animals, they usually will then move on to non-human primates. It's often a type of monkey. Non-human primates, much more expensive to test things in them than it is to test them in rats. So that's why they're not used first off the bat. But after it's deemed to be safe, they haven't seen any bad effects in the non-human primates, then they tested in, human primates, us. So there are usually 3 phases. Phase 1 is a small group of very brave people who are willing to have this vaccine candidate injected. And this is mainly to look to see whether the people's, drop dead or develop some horrible thing. That almost never happens because they've already tested it in animals. Then they move on to phase 2. This usually involves maybe several hundred volunteers, and they're still looking at safety, but they're also looking at the optimal dose. So once phase 1 and 2 have concluded successfully, they move on to phase 3. A phase 3 trial usually involves thousands of people. For instance, both the Pfizer and Moderna phase 3 trials each involved 40-something thousand people. Again, they're looking at safety. They're making sure there aren't any, uncommon bad side effects. But really, the phase 3 trial is also to look for how effective the vaccine is, how efficacious it is. Now, before a vaccine is approved, even for emergency use authorization, they have to demonstrate that it is safe in the average person. Next slide, please. I heard so much misinformation from family and friends about the COVID vaccines. Well, they weren't even tested. Well, excuse me, they were. And then I would tell them how many thousands of people, and they'd go, really? Anyway, What about adverse reactions? An adverse reaction is a side effect that is caused by the vaccine. That's in an adverse event, though, is any adverse event following vaccination. So they sound the same, but they're not. So an adverse event, it might be caused by the vaccine, but it might be a coincidence. But they're looking for adverse events because if there are an excessive number of adverse events during a trial or in, post-marketing follow-up, then maybe it's an adverse reaction. And so any adverse event, no matter how far-fetched that it might be related to the vaccine, those are recorded during these trials, and they're scrutinized by people who know a whole lot more about statistics than I do. So those are two different definitions that sound the same, but they're actually not. Next slide, please. So what about true contraindications? Well, there are some. And a true contraindication means do not give the vaccine. So if anybody's ever had a severe allergic reaction to a vaccine or a component of the vaccine, they should not get that vaccine. Also, specifically for the pertussis vaccine, any encephalopathy within 7 days, that person should never again get a pertussis vaccine. This is much, much, much less common with the newer acellular pertussis vaccine, but it's still, a recognized contraindication. Now, there are a bunch of relative contraindications, and you really have to think about, the individual that's getting it. Some vaccines are safe in pregnancy, but in general, live virus vaccines are not okay to give during pregnancy. Sometimes immunosuppression, you should give them vaccines because it will help them. But sometimes if they're immunosuppressed, there are certain vaccines that shouldn't be given. Again, live virus vaccines in general shouldn't be given to severely immunocompromised. Somebody who's really, really sick, like, in the hospital kind of sick, or they've got a fever of 105, probably forgo vaccination until they feel better. If they've received recent blood products, that can interfere with the immune response to the vaccine. So, you need to look into that if you have somebody that falls into that category. But anyway, every vaccine comes with a set of screening questions that you should ask the patient for that particular vaccine. So I'm sure that our nursing colleagues who give a lot of vaccines, they know all about this better than I do. Next slide, please. But always ask those screening questions of anybody before they get the vaccine. Now, there are a whole bunch of, I put this in the medical myth category. You can't get a vaccine if you have a cold. Well, that's not true. Mild illness, even mild febrile illness, it's okay to go ahead and give it. Some people think that if you're on antibiotics, the vaccine won't work. That's not true at all of any vaccine. If there's a pregnant or immunosuppressed person in the household, that used to be true when we gave oral polio vaccine, but it's not true anymore because we don't use oral polio vaccine in this country anymore. Breastfeeding is a contraindication to vaccine. No, it's not. And actually, sometimes the baby who's breastfeeding can actually get some of the good effects from a vaccine. Preterm birth, there's no reason to not give preemies vaccines. Allergies that aren't in the vaccine, not a contraindication. Somebody who has a family history, my cousin had this bad reaction. Well, that's not a contraindication. And some people think that tuberculin skin testing is a contraindication. It's not a contraindication to vaccinating. It's a contraindication to doing the skin test because some live virus vaccines will interfere with the accuracy of the skin test. So it's not a problem with the vaccine. It's a problem with the skin test. So not a contraindication. Next slide, please. So there are some occasional serious adverse events. For instance, somewhere between 1 in 200,000 to 1 in 600,000 people will have a serious allergic reaction that they need to be treated for, sometimes hospitalized for. So you need to be aware of that, and you should always have the ability to treat an anaphylactic reaction if you're giving vaccines. Severe injection site infections occur in about 1 in 187,000 people. Those shouldn't occur, but occasionally they do. There was a rotavirus vaccine that came out in the 1990s, and they didn't find this during the trials, but once it got out into general use, about 1 in 11,000 babies that got it, they had intussusception, which is a surgical condition of the small intestine. The current rotavirus vaccines do not cause that, though. The original pertussis vaccine caused really high fevers in about 1 in 330 kids that got it. The current vaccine rarely causes high fever. The oral polio vaccine, I mentioned it's not used anymore, but the reason it's not used anymore is that in about 1 out of a million people given it, there was a case of paralytic polio. This was often in a household member who was immunocompromised, not in the actual vaccine recipient. But because of that 1 in a million side effect, we went to inactivated polio vaccine, which doesn't cause that. And then back in 1976, there was an outbreak of swine flu, caused great panic. They developed a vaccine to it, and the vaccine that they developed to that caused Guillain-Barré syndrome in about 1 in 100,000 people. This is still, you still hear echoes of this today. People are afraid of influenza vaccine because they think it'll paralyze you. And there's not been a recurrence of that since 1976. Next slide, please. Let's talk about this gentleman, and I use that moniker very loosely. This is Dr. Andrew Wakefield, a British physician who in 1998 got a paper published in The Lancet, a very prestigious journal, that described 12 children. Now, this guy was a pediatric gastroenterologist. He's not an immunologist or a vaccine expert. But he claimed that he did small intestine biopsies on these 12 kids, and they found the measles vaccine virus in these 12 children that had autism. Ergo, it's the measles vaccine that causes autism. Well, this, really caused people to sit up and take notice. So there were multiple epidemiologic studies carried out to look to see if, this might be the case. Not a single one of them showed a connection. Well, in 2010, this article was kind of quietly retracted by The Lancet because someone came forward and said, we faked that data. I think it was one of the fellows that he had working with him, but turned out that this this wasn't true. But there are millions of people who think that measles vaccines or all vaccines cause autism. And it turned out that Dr. Wakefield was actually funded by a group of lawyers who were involved in lawsuits against vaccine companies. But you don't hear about this very much for some reason. But anyway, this man was responsible for I'm going to say he's got blood on his hands, because there have been people who died from measles because they weren't vaccinated. And it was because they were afraid that it would cause autism. So next slide. There are a lot of other myths out there. Vaccines cause mad cow, they cause AIDS, they cause asthma, diabetes, SIDS, cancer. I put diabetes twice. But no causal link has been found to any of those things. But these falsehoods are out there. There are even people running for president who are out there saying that vaccines are harmful. Nobody should ever take one. Next slide, please. So we're about halfway through now. I think we're doing okay on time. Just wanted to summarize. So vaccines can cause some serious side effects, but they're rare. And vaccines have actually prevented billions of cases of illness. So it's kind of a question of cost didn't benefit. There's a lot of misinformation out there, especially on social media. So you should always use trustworthy sources such as CDC, FDA, reputable medical sources like UpToDate, or there are many others. I did want to, well, I'll do that at the end. Never mind. Next slide. I'm going to show you a book that I really recommend to you. So I actually first gave a version of this talk on childhood vaccines when I was a second-year family medicine resident in 1986. And the reason I gave the talk was because I couldn't keep the schedule in my head, and I couldn't. The best way to learn about things is to have to give a talk on it. So at that time, there were actually 7 vaccine preventable diseases, diphtheria, that were commonly vaccinated against: diphtheria, tetanus, pertussis, polio, measles, mumps, and rubella. That was 1986. Now, there was no new vaccine development for a long time. There were vaccines developed in the 50s and 40s, 50s, 60s, and then it kind of stopped for a good almost 20 years. And it was because of liability. The companies that, do the research, development, testing, all of that, they just didn't want to take on the expense for something that they could get sued for later for millions. Each suit would be for millions. So in the late 80s, the US Congress actually passed an act that established the Vaccine Compensation Fund, or Vaccine Injury Compensation Fund. So anybody that claims to be injured by a vaccine, they can, file for this, and they can get compensated through, a taxpayer-funded system. And this caused then many, many new vaccines to come out because the companies now had some financial protection. So in 2008, I gave a version of this, and there were 14 vaccine preventable diseases rather than 7. So it had doubled in those years. Fast forward to 2023, here we are 15 years later. There's been only one new vaccine for children developed, and that's the one for COVID-19. But what has happened is new and improved versions of many of these vaccines have come out, as well as a lot of different combination vaccines. So it's gotten a lot more complicated. So if you have trouble keeping up with it, believe me, I feel for you. Next slide, please. So, there's been a whole lot. So let's go over these individual diseases and the vaccines that are used to prevent them. Diphtheria. I've never seen a case. And I actually don't know of any of my colleagues who have ever seen a case. The reason we don't see this anymore is because there's been an effective antitoxin that was developed way back in the early 20th century, and then an effective vaccine that's been in widespread use since the 1940s. The organism that causes it is an aerobic gram-positive bacillus called Corynebacterium diphtheriae. Some of these strains produce a toxin that inhibits cell synthesis and causes local tissue destruction. And it forms this thing called a pseudomembrane that is characteristic of diphtheria. I'll show you a picture of that on the next slide. But you can also get a bunch of other complications from it. And the non-toxin producing strains can still make people sick. But anyway, back before there were antibiotics or vaccines, it was fatal in 5 to 10% of cases. In the 1920s, they were recording about 15,000 deaths per year from diphtheria. And we've almost pretty much eradicated it from the United States with the vaccine. Next slide. This is a picture of the pseudomembrane. This is something that develops in the back of the throat. It can actually block the respiratory tract and, cause people to choke and die. Also, the sepsis that it causes can kill you. So diphtheria is a very serious disease and pretty much 100% preventable. Next slide. So tetanus is caused by Clostridium tetani. It's a spore-forming gram-positive anaerobic rod. The toxin that it produces causes this spasm, usually starting in the jaw and neck, which is where it gets the name lockjaw. It progresses to generalized seizures. The spores are all over the place in the soil and will usually enter through a break in the skin. If you're not vaccinated for it and you get tetanus, in the United States with ICU care and all that, most of the cases now are not fatal. But I think I've seen 3 cases of neonatal tetanus and 2 in adults in the 8 months that I worked in Africa, in West Africa. Every single one of them was fatal, despite everything we tried to do for the person. And even if it doesn't kill you, it makes you really, really sick. So you don't want to get it. It's very easily preventable by the vaccine. Next slide, please. The vaccine to tetanus is actually one that was developed again way back in the 30s or 40s. Pertussis causes the disease whooping cough, or at least whooping cough is the name that lay people know it by. It's caused by, again, a small gram-negative rod known as Bordetella pertussis, produces multiple toxins that cause inflammation of the respiratory tract, and they also paralyze the little tiny cilia that clean out our respiratory tract. Because you can't clear the thick mucus that develops in response to the inflammation, people with pertussis get these terrible bouts of coughing. And at the end of that, there's usually this high-pitched whoop, which is where it gets its name from. Unfortunately, the coughing is worse at night, so it keeps people up all night. There are some complications that can occur with pertussis, such as secondary bacterial pneumonias. There's an encephalopathy that is actually more common with the disease than it was with the old vaccine, and which is now incredibly uncommon. And it could cause seizures. It's very difficult to culture, but there is a PCR test for it. Next slide, please. So there is a vaccine, the DTaP. The little a stands for acellular. So it contains diphtheria toxoid, tetanus toxoid, and acellular pertussis vaccine. The newer acellular vaccine causes a lot less serious reactions. You give it at 2, 4, and 6 months as a primary series. Then you get a booster when you're 15 to 18 months and another booster at 4 to 6 years. Now, there are a whole lot of DTP versions, and there are a couple of just DT. Now, the difference between the big D and the little d is for adults. The adult vaccine only contains 1/6 of the diphtheria toxin. And that's to reduce, sore arms and stuff in adults. But anyway, it comes in a lot of different versions with various combinations. And I can't keep all of these in my head. I have to look them up every time. Next slide. I encourage you to do the same. So what about polio? This is a small RNA virus. It has 3 different serotypes. And unfortunately, if you're immune to one serotype, it doesn't make you immune to the other 2. So you have to get vaccinated for all 3 serotypes. Now, actually, type 1 and type 2 have been eradicated in the wild. They no longer exist in the world. I'm sorry, type 2 and 3 have been eradicated. So type 1 is the only serotype left in the world and it's only in 2 countries, Afghanistan and Pakistan. But anyway, the polio virus comes in through the GI tract, through the mouth, multiplies in your GI tract. About 70% of infections will be totally asymptomatic. Another 24 or so percent just result in a minor cold-like non-specific illness. But about anywhere from 1 to 5% of infections will give you a non-paralytic aseptic meningitis. And then a little less than 1% of infections cause the paralytic form, causes a flaccid paralysis, which is often permanent. During the first half of the 20th century, ironically, due to improved sanitation, there were multiple epidemics of polio, and there were a lot of kids who had the paralytic kind, because after all, if a whole bunch of people are getting polio, some are going to get the paralytic version. It used to be, prior to the development of sanitation, most people got polio when they were infants, and because they had some immunity from their mother, they didn't get sick with it, but they did become immune. But as sanitation got better in the 20th century, people didn't get polio as infants. They tended to get it as older children, and they had problems from it. So it was the one place where, sanitation actually made things worse. Next slide. Don't get me wrong, I'm not advocating that we go back to that. But anyway, there were about 21,000 paralytic cases a year. For instance, 1952, before the vaccine was developed, there were 21,000 cases. So the first vaccine for polio, the so-called Salk vaccine, because it was developed by Dr. Jonas Salk, was an inactivated virus, was released in 1955 to much rejoicing by parents all across the country. And then in 1961, there was actually an oral vaccine developed by Dr. Sabin. And the oral vaccine was actually a better vaccine because it gave you gastrointestinal immunity. So for several decades, we pretty much used oral polio vaccine. But the last case of wild polio occurred in 1979 in the United States. And as I mentioned before, today only serotype 1 exists because of extensive worldwide vaccine efforts. But there was this 1 in a million cases of vaccine-associated paralytic polio that was caused by the oral polio virus vaccine, or the oral polio vaccine. So in 1999, we switched to only the inactivated vaccine because it was very, very uncommon. In fact, the only cases were imported, and the inactivated vaccine is good enough for that. Next slide. So the current vaccine actually has more potency than the original Salk vaccine, but it's not quite as good as the oral vaccine. But you give the primary series in 3 doses, 1 at 2 months, 1 at 4 months, and then again at somewhere 6 to 18 months. A 4th booster dose is given at age 4 to 6 years. It's often combined, as you saw in that slide, with other vaccines. There is a standalone vaccine that you can obtain and give if you so desire. Next slide, please. What about measles? I have seen many cases of measles. All of them were in West Africa. I've never seen a case in this country. It's caused by the morbillivirus. It's a paramyxovirus, an RNA type virus. There's only one serotype. It's highly, highly, highly contagious because it's airborne. It usually starts off with a fever and the 3 C's, a cough, coryza, which means terrible runny nose, and pink eye, conjunctivitis. And then this so-called morbilliform rash erupts about 2 to 4 days after you get the initial symptoms. The rash will start up around the hairline and it spreads downward. It often makes kids pretty sick. They lose their appetite. They have a lot of lymph node swelling. They feel crappy. And it actually can kill you. When I was in Cameroon in 1988, I worked for 3 months in a hospital there. We had 4 deaths due to measles in children. It has a lot of complications, some of which are just bothersome, others are very, very serious, including death. In 2018, the last year that I could find statistics, there were over 142,000 deaths worldwide from measles. So it is still a big killer of children. A lot of people think measles, that's just one of those childhood rashes. It's not serious, but I'm here to tell you it is. Next slide, please. So these are pictures of something called Koplik spots. I'm not going to go into great detail, but if you see these, nothing causes this other than measles. There are things that can look like it, but actual Koplik spots, it's measles. Next slide. I've only seen it in Africa again. The rash can be very extensive, tends to become, you'll have little spots that kind of join together or become confluent to make big spots. Next slide. But the first vaccine for measles was a live attenuated viral vaccine developed in 1963. 5 years later, they came out with an improved vaccine. It's almost, in fact, I don't think you can get measles alone anymore in the US. So it's almost always given in combination with mumps and rubella, or with mumps, rubella, and chickenpox vaccine. Get 2 doses, one when you're 12 to 15 months and a booster dose at 4 to 6 years. 2 doses confers immunity in a high percentage of cases. Next slide. What about mumps? I've actually, to my knowledge, I've never seen a case of mumps, but it's also an RNA virus. You get it from respiratory droplets. There's kind of a non-specific early phase that's kind of like a cold, and then you get these big, giant swelling of the salivary glands, typically the parotid gland that's right here on the side of the face. Complications are pretty common. It can cause swelling of the testicles, the ovaries, the breast, the pancreas. You can get a hearing loss. You can get meningitis from it, or encephalitis. So complications of mumps are bad. There was a vaccine developed in 1967, and it has pretty much eliminated mumps from the United States. Next slide, please. This is a picture of a young child with both the parotid swelling as well as the submandibular gland swelling. Next slide. Rubella, another viral disease known as German measles. It's an RNA virus spread again through respiratory droplets, replicates in your upper airway and lymph nodes. It's really a pretty mild disease, honestly. Half the cases don't have any symptoms. The other half get this rash that lasts for about 3 days. It looks a lot like the measles rash, but it's not as brilliant and it doesn't coalesce. The problem with rubella is that if a pregnant woman gets it, especially in the first trimester, it can cause something called congenital rubella syndrome. Next slide, please. Now, this congenital rubella syndrome can cause miscarriages, stillbirths, and severe birth defects, deafness, congenital cataracts, glaucoma, retinal problems, small eyeballs, and can also give you serious heart disease. So the main objective of rubella vaccination is to prevent the congenital rubella syndrome. There was a live attenuated vaccine introduced in 1969 that led to eradication of the disease in the United States. The only cases we see today are imported from other countries. Next slide. So then we come to another viral, This is what the rash looks like, and this is what a congenital cataract looks like, that eyeball on the right there. Next slide. So we come to another viral disease, chickenpox. This is caused by a DNA virus that's a member of the herpes virus group. Again, it's transmitted through the respiratory tract or by direct contact. So it causes chickenpox. You get fever, feel bad, and then there's a very characteristic rash that starts out as a little kind of small red dot that then forms a blister or vesicle, and then it crusts over. If you've had a fever blister, chickenpox looks like little tiny fever blisters all over your body. There are some complications from it. They're more common in adults or immunocompromised people. You can get a pneumonia from the virus. You can get encephalitis. And it can also, in pregnant women, they can transmit it to their fetus, and they can get this congenital varicella zoster virus infection that can cause all kinds of problems. Can be fatal. It's not usually. It's only about 1 in 100,000 in children. But in adults, it's more like 21 in 100,000. So it's much more serious in adults. The virus will persist as a latent infection for the rest of your life in your sensory nerves and can cause shingles. But there was a vaccine developed back in the 90s in Japan. It was introduced in the US in 95 and has led to me not seeing cases anymore. Next slide. So this is what the rash looks like on the left there. You can see the little vesicles or blisters on top of that red macule. This is one of the few things that can affect the palms or soles of the feet. Next slide. Most rashes don't affect the palms or soles, but this is one of the few that can. So usually now this is given as a combination vaccine for measles, mumps, rubella, and varicella. It's usually given in 2 doses, one at 12 to 15 months, the second one at 4 to 6 years. Now because all of these are live viruses, you can't give it to pregnant women, people who've gotten a stem cell transplant. You have to wait 24 months before you give the vaccine. You can give MMR to people with HIV, but varicella you should not give that vaccine to somebody with HIV. If you have a family history of hereditary immunodeficiency in a first-degree relative, you shouldn't get it. If you're severely immunosuppressed or you've been on high-dose steroids for 14 or more days, you should wait because the vaccine may not be effective. Next. All right, another bacterial disease, Haemophilus influenza type B. This is transmitted respiratorily. It can cause very severe disease in children. Lots of different things: meningitis, sepsis, something called epiglottitis, which can block off the airway and kill you, can cause a severe pneumonia, septic arthritis, or cellulitis. I used to see a lot of this. We used to see cases of Haemophilus meningitis commonly. These kids were always hospitalized. It was fatal in 3 to 6% of cases, but about a third of the kids that had the meningitis were left with permanent hearing loss or some other neurologic problems. There were about 20,000 cases a year in the pre-vaccine era. It's declined more than 99% after the conjugate vaccines came out. Now, there was a vaccine that came out in 1985. It didn't really work very well. Next slide. But it was a so-called polysaccharide vaccine. But then they got smart. Next slide, please. And conjugated it to something called protein carriers. There are now 3 different vaccines available that are very effective. 2 of them use a tetanus toxoid carrier protein. Now, this has obviously been rendered harmless, but it makes the vaccine much, much more effective. And then the third one uses a meningococcal outer membrane protein for the carrier. Now, it's important to know which one you're using, because the one that uses the tetanus carrier protein, you need 3 doses for the primary series and then a booster at 12 to 15 months, whereas the one that uses the outer membrane of the meningococcus as a protein carrier, you only need 2 doses for the primary series. So it's important to know which one you're using. There are 2 combination vaccines that have DTP. One has or they both have IPV. That should say IPV, not IVP. And one of them is actually against hepatitis B as well. It's important to know which one because they're 2 different vaccines for the Hib part. All right, next slide. Don't worry, we're getting close to the end, but I think I'm going to run over the top of the hour here. Pneumococcus, another bacterial disease. There are about 100 different serotypes, but only a few are common. Most people carry this around with them all the time. It's in your respiratory tract, usually doesn't cause you any harm. Unless you're lacking a spleen, then it commonly causes invasive disease. There are also some ethnic groups, one of which is American Indians and Alaska Natives, that are at higher risk. Next slide, please. So the original pneumococcus vaccine was one that was developed, so-called polysaccharide vaccine, that was effective against 23 different forms. This is just a picture of the pneumococcus. It's a gram-positive two bacteria together often. That's why it's called a diplococcus. As you can see, it causes a whole bunch of very serious diseases, including meningitis and pneumonia, osteomyelitis, and sepsis. Next slide, please. So the original polysaccharide vaccine is pretty good, but it's not as good as the more modern conjugate vaccines that use a non-toxic form of diphtheria toxin as the protein carrier. The original conjugate vaccine was PCV7. It was only good against 7 rather than 23 strains. But then they came out with PCV13. 7 and 13 aren't used anymore. There's now 15, and just recently PCV20 came out. So the recommendation for this is you give it at 2, 4, and 6 months with a booster dose around a year to 15 months. The old polysaccharide vaccine is recommended in children after the age of 2. It's not very effective if you give it before 2 years of age. These are kids with certain high-risk conditions, but as the PCV20 gets rolled out and becomes more common, we may not need to do this anymore. So stay tuned on that. Next slide. Hepatitis B, it's a DNA virus, can cause acute and chronic hepatitis. Most adults, if you get it, you'll eliminate it and it won't become chronic. But if you get it as an infant, about 90% of infants who are infected will develop chronic hepatitis B, which leads to cirrhosis of the liver, failure, and hepatic carcinoma. Next slide. There's a very good vaccine. The current recombinant vaccine came out in 1986. There's been about a 90% decline in hepatitis B cases since that vaccine came out. There are several different ones and combinations available, but typically it's given just after the baby's born while they're still in the newborn nursery, then at 1 month and 6 months. Now, there is a newer vaccine that has come out for hepatitis B, but it's not for use in children. So be careful not to use this one. It's not approved for children yet. Next slide. I think hepatitis A is next. As opposed to hepatitis B, which is a DNA virus, hepatitis A is caused by an RNA virus. It's typically acquired fecal orally. In other words, you get it by eating, I'm not going to say. Anyway, it replicates in the liver, causes sometimes a terrible hepatitis, but it almost never becomes chronic. If you get it as a child, it's usually asymptomatic, but if you're an older kid or an adult, you usually get pretty sick with it. Complications are pretty rare, and it doesn't give you the chronic infection, but there's a great vaccine for it, and it has low side effects. So after the vaccine was released in the late 90s, cases declined by 95%. However, starting in 2016, started seeing an increase mainly in people who were using drugs or people who were homeless. Next slide, please. Probably due to sanitation issues. Now, the vaccine, it's an inactivated viral vaccine, has an aluminum hydroxide adjuvant. Be careful, there are 2 different vaccines. And there's a combination vaccine with hepatitis B, but the formulations for adults and children are different, so make sure you're using the pediatric vaccine in kids. Next slide, please. Almost finished. Rotavirus, another RNA virus. You get it through the fecal oral route. Replicates in the small intestine, and in little kids, it can cause a really severe diarrhea. This is a very hardy virus. It can last for a long time on surfaces. If you get your first infection after you're 3 months old, your maternal immunity has waned and can be pretty severe, can last up to a week. And it actually causes about 500,000 deaths of infants annually worldwide. Don't see kids die from it much here, but in the third world, it's a common cause of childhood death. Next slide. The first vaccine that came out in 98 caused this um, complication, and so it was withdrawn from the market. So then two different vaccines came out later, one in 2006, one in 2008. They are different, and one requires 3 doses, the other only requires 2. So it's important that you know which one you're giving. They're both oral, that's not a shot, and you don't give it after the kids turned 8 because kids past 8 don't usually get deathly ill with rotavirus. Next. I think is influenza. I won't go over this because we're running out of time and most of you are pretty familiar with it. Next slide. Influenza vaccine is recommended for, go ahead to the next slide too. The influenza vaccine actually causes more hospitalizations among young kids than any other vaccine preventable disease. There are 3 different kinds of vaccines available. And the vaccine composition changes every year. It's a little complicated for kids under 9. They need to get 2 doses the first time they have it. After that, they can just get it annually. Next slide. And then the only new vaccine developed in the last 15 years for children is the COVID-19 vaccine. Next slide. It usually causes a fairly mild disease in kids, but there is this complication known as MIS-C. It can be very serious. There are 2 different vaccines that are approved for use in kids 6 months and older. I think you're all familiar with these. And then there's one recombinant subunit vaccine, but it's only approved for kids 12 and older. The schedules for these vaccines have become very complex. I would suggest that you go to this CDC webpage. It's got a great chart on who needs COVID vaccine and when. Next slide. The monovalent mRNA vaccines should be off the market and off your shelf. The Janssen vaccine is no longer available. That got taken off the market in May. Novavax is still authorized for now for a primary series. And the plan is by the end of September, which is coming up pretty fast, there's going to be an updated COVID vaccine that's targeted against the XBB.1.5 variant. Next slide. It's one of the Omicron subvariants. So just some resources. The CDC website is a great resource, as well as this handy dandy chart that the CDC puts out every year. It's all nice and color coded and very good to have in your clinic. This is the so-called pink book. It has every vaccine you'd ever want to know about in it. If you give a lot of vaccines, I would suggest you get a copy. It's pretty inexpensive. And then I highly recommend this book. It's called Vaccines. It's by Dr. Susan Weisberg. It's a great book that goes into every vaccine and it tells the good, the bad, and the ugly. And she claims to be non-biased. And reading the book, I think she gives a pretty balanced view. She does tell about the rare bad side effects, but she also tells about the risk-benefit ratio. And I think that's the kind of take-home message there. I think this is the last slide other than the goodbye one. Next slide. Yes, it is. So if you ever have questions on vaccines, I'm available for consultation either by email or my phone. And I don't know if we have time for questions, Brian. We're already 8 minutes past the top of the hour. People probably need to get back to work.
I mean, we can take questions if people want to stay. Any questions?
I have a question from Emily. Does
yes.
RSV immunization transfer well through breast milk. Emily, I'm going to have to get back to you on that. The RSV immunization is very, very new, and I've not studied it well enough to know the answer to your question. I think from the little bit that I do know about it, they are recommending giving it to pregnant women so that the infant will get it, but I don't know about the breast milk issue. So
Oh my
I'll
God.
research that and get back to you.
Harry, Dr. Brown.
Yes.
Yes, I saw that you don't have HPV vaccine. Um,
Yes,
and
I'm going to do a presentation sometime in the future on adolescent vaccination, and that'll be included in that.
the thing is that some websites said to vaccinate at 9 years old, male and female.
Mhm.
And then others are saying 15 years old. There's like no what's the word?
There's no uniform
Right,
recommendation.
exactly.
Yeah.
Exactly.
So the thing about HPV, of course, it's it's designed to prevent infection from human papillomavirus, which causes cervical cancer in females, and it causes genital warts in males and females. It's the vaccine is very, very good at preventing disease. So when you give it, is kind of a matter of well, you want to give it before people become sexually active.
Mm-hmm.
And 9 years old might be a good time to give it. um, most
See.
kids at age 9 are not sexually active. They certainly shouldn't be, but in my opinion. But if you wait until they're teenagers, like especially older teenagers,
They're hard
17,
to
18,
get. Yeah.
19, it you may have missed the boat. So
Yeah. Yeah.
earlier is probably better. But I'll cover that in the later presentation.
Okay.
Okay. No other questions. Don't forget to fill out your survey and join us for next month's infectious disease echo on September 8th. Thank you all.
Thank you, Dr. Brown.
Dr. Brown, can you
Thank
stay
you,
on, please?
everybody. Have a good day.